Good day, everyone. Thank you for joining this online session about improvement of the range of motion on upper limbs. Before starting, as usual, I will do a quick introduction. My name is Mary-Christine Collette. I'm an education specialist representing the interest of the Swiss Dollar-Class Academy. So what is the Swiss Dollar-Class Academy, called the SDCA? This is the training organization which has been created by the Swiss company EMS, Electromedical Systems, who initiated the Swiss Dollar-Class method in the early 2000s and who launched shockwave training programs worldwide as of 2013. Also, the guided dollar-class therapy GDT concept has also been created by EMS with the aim to push shockwave, laser, and rehabilitation exercising and offering full concept for practitioners worldwide. Before starting this webinar, I will provide you a quick few technical tips. As you can see on your screen, you have a Q&A and chat icons. Please feel free to use them during this webinar, and we will answer your questions at the end of the presentation. You will have also the opportunity to have a live session with the two trainers we have invited today. And we have a pleasure to welcome today our faithful experts from Germany, Peter Stiller and Alex Sablas. Thank you, Peter. Thank you, Alex, for being with us today. I don't give you too many details, so they have some long time to introduce themselves and offer you their presentation on practical session on upper limbs. That was for my side for the introduction. So enjoy the session and see you at the end for the question session. Thank you.
So hello, everybody. Nice to have so many participants in there in the last webinar that we do, the third and last. We will not introduce ourselves again, I think, because everybody knows us now. And for the guys who are here for the first time, we are not doing any theory today. We did it in the first part, very long, and the short part in the second one. So now we'll only do cases and live treatment at the end for today's topic on the upper limbs, how you use shockwave, and for example, the laser we'll show you. Now, I will start my slides. This? Yeah. Can you see it? MC, is it good?
Yes, perfect.
Okay, perfect. Okay, so let's start. Today, we said that upper limb is not enough for us because we had lower limb and now upper limb, but we didn't talk about the back. So we put all the back things and the cases about the back into this webinar for today, because in our opinion, treating the back with shockwave is very, very important, and very, very broad treatments are possible. So, as I said, we will not introduce ourselves again. Very, very short, only one slide. What is the aim of, what is the aim of modern shockwave therapy that we have in every treatment that we do? Is no or less medication, no or less injections, of course, no or less operations. And what is very important, we are working non-invasive, so we have low risk when we are treating, and it's very, very effective what we are doing. So what we want to achieve is a happy patient, and a happy patient is also for us a successful practice. Let's start with the cases. I will start with a topic that is, for me and for us, it's very important in the last, I would say, 3 or 4 years. It's coming up more and more. It's a frozen shoulder. This is the stage 1, 2, 3 that you see here is not something that I normally use, but I wanted to show how it is in RCTs, for example, how they divide the stages that you can have when you have a frozen shoulder, because it can last very, very long. In our opinion, the stages are going fluently into each other. So the most important thing is to know that we have at the beginning a very bad pain, then it goes into a really very fast decrease of the mobility, which is the most for the most of the patients, the most severe problem that they have, because they cannot use their arm. And then after month and month, it is going away in a very slow way. And after about, in this case, 27 to 33 months, that's one study that we took out, it gets better and better, but that's only if you don't do any other treatment than physiotherapy. We also had studies with a 4-year follow-up, and they needed 4 years to get better, the patients. So my example starts with a woman who was a head of a children's home and mother of 2 children on her own. So she had a very busy day with a full job and being mother of 2 children. And she had an overuse in May of 2017 of her shoulder when she was doing very hard work in her garden with very heavy stones that they had to lift there. And after that, she got more and more painful range of motion in her shoulder, as she had a lot of treatments by an orthopedic in Germany who did multiple cortisone injections, oral cortisone, until she had more than 10 kilograms of increase of her weight. She had various painkillers up to morphine and physiotherapy. And after 3 months, in August 2017, we had this kind of MRI that showed a severe capsulitis and peritendinitis and bursitis. So as we always see, there's more than only the capsulitis that makes the frozen shoulder. And the most important thing was, next to the bad pain, she had an abduction of 10 to 15 degrees. 10 to 15 degrees means she couldn't lift her arm to change her clothes. She had to have help from her children to get her clothes on and off. It was really a very bad time for her. And I saw her in October 2017 because our children are going into the same school. And she asked me if there's no other treatment than only painkillers and physiotherapy. And I said, no, we have a way that I think is much faster. And so we started immediately with radial shockwave therapy. We always start with the big applicator and treat the whole shoulder and the neck and so on. We're doing more than only 1 or 2 parts where it is painful. We're doing the whole shoulder. And at the beginning, we could only put 1.5 bar on her shoulder. That's really little for a shoulder. Normally, you can use 2 bar, 2.5 bar. And it was so painful at the beginning that I couldn't go or couldn't increase the working pressure. And we also did the laser, of course, because of the pain. We wanted to get the pain down easy and very fast. We did cryolite treatments. I talked about cryolite the last webinars. It's a hyperbaric CO2 cooling therapy, very fast, very strong cooling. And it's very good for people suffering from so much pain in a joint. Medivit Cryos is a cooling bandage that we use very, very often. And for example, WOP enzyme is an enzyme that's anti-inflammatory, and Traumale is a homeopathic kind of anti-inflammation that we always give the people as pills. After 5 treatments, it improved very, very fast. After 5 treatments, she was completely pain-free and could, or nearly completely pain-free, and could sleep very well. The range of motion got better and better. And after 8 treatments, we had an abduction of 120 degrees. That's really fast. We also had treatments or therapies where we had to do 10 or 12 or maybe 15 treatments to get this result. But it was really, for us, made us really happy, because she was suffering so much for so long, and she could go back to her work and could do her everyday life. and she's still entirely symptom-free until today. She had no coming back problem. Just to show you that there is also scientific proof that it works on a frozen shoulder to do a shockwave. Here's the RCT from 2016, where they worked with radial shockwave therapy, and they said it's working very, very well at a shoulder adhesive capsulitis, which is the same as frozen shoulder. As I said, we put the back into our webinar today because for us it's very important. You cannot treat the shoulder or the whole arm without treating the cervical spine or the neck part. And I have an example of very strong and athletic patient with 59 years old. He wanted to quit his job now because he was a manager of a company and had worked enough in his life, and he wanted to do more sport. But in the same year as he decided to do this, he had very strong pain in his neck and his lumbar spine part. And here you can see the MRI of the lumbar spine, and at the end of the slide you see what he was suffering from. Had severe lumbar spine complaints. He couldn't get up from a sitting position, and occasionally he had effects on his thigh, on the dorsal side, with feeling numb and being very bad pain into his legs. As you can see on the MRI, there was nearly everything. He was suffering from spondyloarthritis, facet syndrome, osteochondrosis, and the spinal canal stenosis. And that was the problem because he went to a clinic here in Augsburg. It's a private insurance clinic, so it's one of the better ones, I would say. And they told him not to operate at the moment, but in the next few months he will have a spinal fusion operation. And that shocked him because now he comes. He had the same problem at his cervical spine, and they told him the same there. As you can see here, it's also a very severe MRI findings, also with spinal canal stenosis, also with osteochondrosis, a narrowing of the neuroforamina. So he nearly had everything. That's why he was suffering from really severe cervical spine pain. His neck was always stiff. He had tension headaches every day, and his fingers got numb or tingling more on the right than on the left, especially by night. So he couldn't sleep anymore. And the clinic said the same. They first said, oh, just physio and traction, no surgery. But in the next month, they would have to do surgery on his neck and do a fusion because he will not get pain-free without the surgery. It's the same here. They said midterm, at midterm, they would do the spinal fusion surgery. The funny thing was that midterm means in the next few months. And he went out of the clinic and had an operation appointment on Monday next week. So he said, I don't want to be operated because I want to do more sport. And I said, with this fusion operations in your back, you cannot do the sport that you want, because he's cycling very much. He's doing very big journeys with his bike, about 3,000 kilometers around Fuerteventura, for example, or he was getting over the Alps in Europe, which is very, very a very strong thing that you need. There's a lot of load to do when you do this, and that wouldn't be possible with this. And for this patient, it was horrible to hear that he couldn't do his sport anymore. So what did we do? We started to treat all these problems by a shockwave. As you can see here, that's a EMS dollar class classic that we used, and we did it as well on his neck and his cervical spine, as well as on his lumbar spine. And this was the result after we did it once a week. At the cervical spine, we only use 1.0 bar to 1.2 bar, not more. It isn't necessary to do more. And all the other parts, we work with about 2.0 to maybe 3.0 bar on the lumbar spine and on the neck. And after 3 treatments, he was nearly pain-free. He has a visual analog scale from 1 of 10. Before that, you saw that he was at 7 to 9. And the same was with the lumbar spine. After 4 treatments, we were at 2 points of 10, and he could do everything again that he wanted to do, and still is doing everything today without operation. We didn't have to do any surgery, and he did 2 very big cycling loads. He was, as I said, going over the Alps and at Fuerteventura, 3,000 kilometers, very, very strong without any problem. What we see a lot is the chronic tension headache caused by osteochondrosis of the cervical spine. That's in this case, it's also going into the arm and the fingers. It's going to be numb more and more, and the tingling fingers that you always see with these patients. And the MRI of this patient showed us the osteochondrosis and the facet joint arthrosis. This is, in most of the cases, this is the problem why they get these neurologic problems and the massive tension headaches. And we always treat them with shockwave because nothing is faster, nothing is better in treatment. As you can see here, she had a lot of therapies. For example, the chiropractic therapy, physiotherapy, medical rehabilitation therapy, pain therapy with a lot of NSAIDs. She had acupuncture, fungo means warming therapy, magnetic field therapy. She had everything, but no benefit, and not more than about 2 or 3 days. And then we said, okay, let's do the same with shockwave. And as you can see here, she was really suffering from myoglosis. She couldn't move her head in the rotation the right way. She had pain by doing pressure on it. She had pain by movement, and the tingling fingers were getting more and more, and she couldn't sleep anymore. And so we started very carefully with radial shockwave from about 0.9 to 1.2 bar at the beginning. At the neck, at her neck and the cervical spine. Okay, and we did and that's very important, the occipital trigger points. That's very, very important. We go up to the occipital trigger points to get this massive pain that is going into her head, the tension headache away. And the funny thing about this is, if you go in the point, you have, in most of the cases, a real pain that the patient tells you, and then you tell them, okay, stay like this for about 3 to 5 seconds, and then the pain will go away. And in 99% of the cases, that's really true. And then you can go up to 1.2 and 1.3 bar, but you don't have to have more. If the pain goes away, you can leave the occipital trigger points and go back to the neck. And that's the complete therapy that you need. And in this case, and that's the result that we always see after 3 sessions, she had a massive improvement of the pain. And the cervical movements, the range of motion, it gets better and better after 5 sessions. It's completely free. The movement of the neck and the cervical spine is completely free. And then after that, you have to go on with the therapy, because this is something that you cannot heal the complete osteochondrosis, but you can get the inflammatory part away. And that's important. And if you do this every 6 to 8 weeks, one treatment in 6 to 8 weeks, then you can hold this result. And that's the I would say the greatest thing, that you can tell the people, okay, you come 6 to 8 times a year, and you will not have any problems anymore. As you can see in the last sentence here, she never had any tension headaches again, and the neurologic problems in her arms were gone forever. This is once again a horrible case. It's a collarbone or a clavicle pseudoarthrosis after a massive trauma. And this woman fell from through a glass roof when she was taking photos. Was her job at this time, and she fell about 4 meters. Had a complicated multiple fragment fracture of the collarbone on the right side. She had a AC joint dislocation and a serial rib fracture on the same side. She had, because of the problem with the clavicle, she had 8 operations, 4 times osteosynthesis, and she got 4 times pseudarthrosis after these operations. And so this was going up for 4 years. Then she was suspected to have a Sudex disease. You will see pictures after that that prove the Sudex disease, and you will see it with one look at this. When I saw her after these 4 years, she came to me, and I saw her. She had unbelievable pain when you put pressure on the bone or let her move her shoulder. Then the pain was between 3 when she didn't do anything and 8 when she were moving. When she was moving, then she couldn't sleep anymore. Of course, the abduction and the anteversion were decreased a lot. You see that in the next slide again. And she had a bad swelling over the scars from the operations and the lymphedema of the whole arm. And here is 1 year ago, there was an assessment that said that she will have a permanent functional damage of 3 of 10. That's what we do in Germany to say they get something from the insurance, and to say how much they can get, they have to say how bad the movement is after a trauma. You see it here in degrees on the right side and on the left side. Means after 3 years of physiotherapy, pain therapy, and so on, a very bad range of motion. And that was something that she couldn't accept. This is a picture before the last osteosynthesis, just to show you the hypertrophic pseudarthrosis. Do you see it here, the gap where I think you can see where the arrow is. And after the last osteosynthesis, at the beginning, it looked like that they have a success. After 6 weeks, it looked like only cloudy and dimmed fracture gap. So she was happy to hear that, but 6 or 7 weeks later, we had the same problem again. Under the plate that did the osteosynthesis, the gap got wider and wider. So they talked they told it a pseudarthrosis again. And after that, she went to the internet and found Professor Smits that I introduced you last time as one of the most famous scientists working on pseudarthrosis. And then she came to me because Professor Schmidt said he couldn't treat her at the university. And we started the treatment because of 2 things. Because of this arm that you see here, this is a Sudex disease, a chronic regional pain syndrome that comes after that long time without any improvement of the fractured bones. And it's a very severe thing for her because she couldn't use this arm as she wanted, and it is painful into the complete arm and hand. And so I said, okay, let's start with a shockwave therapy and all the other things that we do normally, like as you had before the laser, the cooling therapies. And we do, in this case, of course, vitamin D3 as part of the bone, the working bone the bone can only work if it has enough vitamin D and calcium, and that's why we give this every patient. The vitamin E is meant for antioxidant, means for anti-inflammatory use, and in this case the cherry juice, Montmorency cherry, is very anti-inflammatory, that you can give without giving her any drugs like NSAIDs. In this case, we started initially with radial shockwave with a big applicator. In the second treatment, we could do 2.5 bar, which is a lot at this area where it is so painful in the pseudarthrosis part. Then after the third treatment, we changed to the Power Plus handpiece. The Power Plus handpiece is stronger than the normal Evo Blue handpiece, and we use it nearly only for pseudarthrosis to get more energy in there. When we used this, we could do 1.8 bar, which is a lot with this handpiece, and we started to do the focus shockwave. That's when we clearly can say where the gap in the pseudarthrosis is. We sometimes use it in combination with the focused shockwave, and in this case, we did it because we said, okay, after 4 years of suffering from pseudarthrosis, we want to have any energy that we can have into this gap. And after the fourth treatment, the arm started to get lighter, the heavy feeling went away, the moving improved. She had no more pain after the fifth treatment, no more pain in the arm and no more pain in the collarbone. And after the sixth treatment, we had nearly a full range of motion. That was really impressive because we didn't expect this. As you saw before, after 3 years, she had 3 of 10 parts that were not able to get back into the movement. And now, after 6 treatments, we had a nearly full range of motion. And after 9 treatments, we did a check with the CT. Now you see the metal, the lighter part here is the metal, the plate that is lying on the bone. But you can also see that, I will start the video. You can also see that here where the arrow is, there's no gap anymore. The hypertrophic gap is completely gone. Here is a 3D version. It's the same picture, but in 3D, and where the arrow is, there was the gap. Wait a second, it comes back in a few seconds. There's no gap anymore. So perfect result. That is what the findings in the MRI were when we did the control MRI, increasing consolidation of the bone. And also for this, for the non-unions, there are a lot of RCTs. This study shows that you can do the same that we always did with focused studies with radial shockwave. This is a work of Professor Smits again, and he showed that radial shockwave can have the same results than focused shockwave when you treat pseudarthrosis. Okay, now the next is the chronic polyarthritis. This is something that Alex will tell you. Wait a second.
Warm welcome from my side. I present some polyarthritis cases on the hands. The first one is a 65-year-old female patient with a severe polyarthritis of both hands. The patient has been unable for full strength in her fingers or put on the wedding ring due to exercise swelling for nearly 12 years. She is in pain every day and has to spend 10 minutes painfully moving her joints every morning before to get up and start the day. This is the way the fingers look like. As you can see on the pictures, you see the swelling in the joints and the deformation in the joints. So what we did is we started with shockwave therapy, as you can see on the pictures, palmar side of the hand. You can see in the back also how much pressure we use. What happened is that after starting shockwave in June with a large applicator every 4 to 5 days, after 4 treatments, this patient had no further symptoms of her everyday life. Problems were gone completely. She could straighten her fingers again, except one on the right hand. She's wearing her wedding ring again for the first time since 10 years. We did further treatments with shockwave once every 2 weeks until August. Then we reduced it for once every 4 weeks, and since November, just once every 6 to 8 weeks for maintenance. A second case, which I tried to show you what happened to the hand every single days. This was a 60-year-old patient suffering from chronic polyarthritis since 28 years without painkillers. She was not able to live her life. The initial treatment was because she was very, very painful in her finger joints. We used the laser therapy on all basic finger joints. Each 4 minutes after 1 hour pause, we started with a shockwave. Could already start 2 bars with 10,000 impulses and maximum frequency, and the cooling device afterwards. So this was before we started the treatment, 19th of April last year. You can see the big swelling in the hand, the deformation, not able to straighten the basic finger joints to wash her face or cream her face. The results after the third treatment 4 days later was, as you can see, yeah, the color of the skin is looking healthy again. The finger swelling is reduced a lot. She can straighten the fingers already better. So we did another 2 treatments. This is the result after the 5th treatment. 3 weeks later, you can see the skin is almost all swelling is gone. She can move the fingers properly. The pain is gone. If you see it, a result after 15 days with a total number of 5 treatments, this is an incredible result after such a long period of time of suffering, pain. Just to show you, this is also a case which is open access finding. Yeah, so just if you want to look it up again, no problem. Another important, we already had the non-union case of the collarbone. I want to present just to what can be treated. This is a fracture of the hand. It's a very fresh fracture, as you can see. It's 2 days after surgery. We're going on this place for lymphatic, reduced lymphatic edema, for reducing pain, and also for starting the healing process of the bone. You don't have to be worried. This is something to be started very, very early. Another important, when we present later on the epicondylitis, I just show you the bursitis or capsulitis of the elbow. This was the patient coming to the practice. You see the huge swelling of the elbow. It was very painful. Extension was impossible because of pain. Normal flexion was possible because of the pain. And the result after just 4 treatments is, as you can see, we could reduce the swelling. The color is normal. Full extension on the right picture is possible. So this is just a very quick result we can gain with doing shockwave on these kind of injuries. Peter already mentioned the trigger points in the upper back. I just want to show you how we treat these kind of trigger point things. This is, I think, the worst example of somebody sitting at the airport waiting for his plane to go, even if it's a surgeon for the spine. So he need to be treated definitely with trigger points. The pathophysiology of trigger points, quite simple. We had in the first webinar, we were talking about substance P and the inflammatory mediators. This is the study just showing that's why we can use shockwave for treating trigger points. This is a combination therapy case of a young football player. We start with a short laser therapy on each trigger point, which is not quite necessary, but very helpful. Then doing 200 to 300 impulses of shockwave on each trigger point with maximum frequency, the special trigger point applicator. And we get an immediate release of the neck pain of the patient. Then we treat him with a hyperbaric CO2 cooling device, which is also just increasing our shockwave therapy, and give him some homework. This is also open access and has been published. So to look it up, just ask for email addresses. I will switch over for spasticity on hand and foot to Peter.
Now we're going in a very different way because spasticity is a problem of the whole body, of course, but we always see it when the guys have problems after an apoplex or something with their muscles. They're not doing what they want. This kind of spasticity that you see in the picture is a case from someone who was suffering from lung cancer, then had brain metastasis, and during the surgery that they did on his brain, he came out with this spastic hemiparesis on the left side. Then we had an MRI of the left shoulder that showed a lot of things in his shoulder that you don't want to have normally, but if you have a spasticity on this side, you have two big problems. So this is a combination of the spasticity problem and the frozen shoulder that we saw before. And you see on the right side that he used to take a lot of medication, but the pain didn't go away. Here it shows how it was after the surgery. The left picture shows you that the arm is still straightened, means that he cannot use the arm at all. And after a few weeks, it's going in this position, as it is typical for spasticity. You will see it in the next video too. Here you can see that the arm cannot be moved properly. He cannot use his muscles. And here you can see that this is the normal.
Nach 3 Stoßwellentherapien bei Dr. Stiller geht meine Schulter schon so viel besser. Schmerzfrei.
What he's saying in German is that he couldn't move his arm from the 90-degree ankle to any other ankle. And now it is the case that after 3 shockwave therapies on his arm, he can do this movement that you see on the left side, in the video. And a few weeks later, he could do his own training. As we want to show you, you can see that there's a lot more range of motion than he had before, and that's pretty normal for spasticity patients. And what we can show you, this was an SDCA course in Germany. This is a friend of us, Thomas Meyer, a physiotherapist and shockwave therapist for years. And we showed him this case and told him to work, because he didn't know the patient. And in front of the audience, we told him to treat him as he always treats spasticity. And it was really, really impressive how good the result was after the next treatment. And you can see what I want to show you here. And you can see that he's not only working on the arm, but also on the neck, as we always do. We're working on the whole muscle chain until the cervical spine. And here you can see he's changing the applicator. That is very important, because when you find the trigger points where the spasticity is triggered to, you can go, as Alex said before, on these points with a smaller applicator and get even more energy into this special point. So we can see now he's going on the muscles where the spasticity takes place, where the myogloses are in. And then he can work on his arm by stretching the arm during or while he's doing shockwave. Wait a second. I have a little technical problem at the moment. I'm sorry. Okay, sorry. Now it's better. Now you can see while he's doing shockwave on the muscles at the whole arm, or where you can see that the elbow, the patient is able to stretch the arm better than before. It's not spasticity, it's a myelinosis problem, but what we want to show you is that we can also use shockwave for acute problems. In this case, it's the thoracic spine, an acute thoracic spine syndrome in a professional football player. He had an acute pain in the middle of his left thoracic spine during a training on Wednesday of the week that we started the treatment then. Initially had physiotherapy, heat and rest after that, but he couldn't even move properly. And in the evening of the same day, he called me on the mobile and said, I cannot breathe deeply, and I'm getting frightened. And after that call, he came to my office at 10 p.m. For a treatment, because that you cannot do the night like this. And the findings at this point were very strong hardenings, like a cord in the middle of his left thoracic region. Means the paravertebral muscles were much too hard and too painful. And so as every trigger point on the left side of his spine was painful, we started the treatment at the trigger points and the complete left paravertebral muscles. And you see, we did 9,000 shockwave impulses for one treatment of only the left side. So it's a lot that we did, but it's a big professional football player. He's more than 1.90 meters high. And so you treat the whole back on the left side. And after that, you can do very easy chiropractic, and the thoracic spine was able to relax at once, and he had no problem when he could breathe deeply, and he had no problems by walking or turning his body when he went out of my practice. And the next day he had a light training without any problems. We did shockwave and their physiotherapy again. On Friday, 2 days later, he could do a full training it's the first league in Germany. It's very intensive professional football. And on Saturday, there was the next match against Wolfsburg in the league. And as you can see, the treatment was successful because he was the player of the match, the star of the match. In Germany, they always have one star of each match in the first league from the press. And he scored one goal and another one. And so you can see he could do everything after 3 days again. This is possible only by using shockwave. No chiropractic or no physiotherapy could do the same without using shockwave. Okay, this is our last case now. It's an impacted radial fracture. We have a very good documentation of this case because this is the elbow of my wife. She fell from a horse in December 2020 and got this bad fracture. She was the MRI showed that it was compressed, and the head fracture had a gap of 4 to 5 millimeters, which is normally, as special elbow surgeons told me, normally a case for a surgery, for doing surgery to get the bone into the normal position again, because you don't have, in this case, the joint line that you normally need will never come back, and they say you have to do surgery to get it back to have the same range of motion again. But one of these surgeons said, you are doing shockwave very well, so if you want, you can try all the conservative things before we do the operation on the arm of your wife. And I said, okay, that's what I wanted to hear. And then we did. Now you can see it here again. It's a bad fracture. And then we did what what we always do, we try to get the pain away, use the high energy laser. We used cryolite, of course, against the swelling because she had a bad swelling in this elbow. And we started radial shockwave for daily use 1 day after this happened. As you can see it here, it's the 18th of December, it's 1 day after the fracture. And of course, cooling bandages. We did passive physiotherapy from the first day on. I have to say that my wife is a very strong wife. Others would say it's too painful, but she did everything that I told her, and she did it very well. And for the night, she had a lightweight plaster just to keep it in form. 4 days later, we started with focused shockwave 2 because I wanted to have the most energy into this gap that is possible. And she got an orthesis where she could bend the arm and use the joint, but not get away in the medial and lateral part of the elbow. And we started to active physiotherapy exercises, so she was beginning to use her elbow on her own. At the 28th, it's 10 days after the first treatment, she was nearly pain-free. We didn't use the plaster splint at all, also not in the evenings, in the nights. And the X-ray control after 10 days showed a perfect position of the fragment, no dislocation at all, and so we could go on with the therapy. And I show you some videos. Where you can see, I tell it in German in the video, I'm sorry, but the most important thing is that you can see what range of motion comes back after about 14 days. First of all, she had a range of motion of 10 degrees, not more. And now you can have a look what she's able to do. Okay. So this is the range of motion after 14 days of treatment with this fracture. I think this is really a great result. And now I will show you how we use the shockwave every day on this bone and the whole muscle chain, because you have to work on the whole muscles that are surrounding the elbow, of course, because you have to work against hardenings, bad positions of the muscle and the tendons, and you have to use it also for the fracture, of course. As you can see now, wait, show you. There you go, completely. As you can see, my wife is going up with the pressure herself. She tells me, okay, that's okay, I can go up. And I told her to go up on her own. She can tell it's too painful or it's okay. And now after 19 days, we came from 10 degrees movement to now much more than 90 degrees. Yeah, perfect. And she's doing these active movements on her own while I am treating. Okay. Then from the 21st day, so the third week, we went from once a day to 2 times a week shockwave. That's enough. And now you can see what she can do after 3 weeks. I mean, we are talking about an elbow fracture, radial head fracture. Normally you have a plaster for 6 weeks. Now we are at 3 weeks. And this is, these are the things in her daily life that she can do without any pain. Which is very, very important because we have 4 children. So she has to do a lot of things in her normal day life. For example, opening a bottle or using fork and knife for eating and for cooking. And 2 days later, that was very important because after 3 weeks, we didn't have any more holiday for the children, so she had to bring them to school and so on. And it's very, very important to use the car. And as you can see, it's the left arm. She can do everything with this arm while she's driving. And this all without operation. And then we went on, of course, with the treatment for the next weeks. And after 6.5 weeks, she had the full movement and full strength. And after 7 weeks, we did an MRI that said remarkable improvement in the sense of a reached position of the fragment. That's really, really great. You will see it now. That was the fracture at the beginning. And that is really the result. It's mirrored here, but that's the result, how we got the joint plate back into the position. I think we only could do this by shockwave because if you activate the osteoblasts while you are working on the elbow and doing the normal movements as fast as possible again, I think you have a possibility to get such a fracture back and the healing in a perfect way. And this is at the end of this 6.5 weeks, she could stretch her arm completely and get back into the full movement, which was really impressive. Okay, at the end of nearly all our webinars, it's on George Best to say what is most important for shockwave. Pain is temporary. The patient has to feel the pain, of course, but the glory you get from the treatment is forever. Okay, thank you.
Thank you too.
Oh,
Do you have,
I forgot this picture.
before we continue with the practical part, we want to answer some questions to the cases. What we're gonna do in the practical part will be the trigger finger, will be the tennis elbow, golfing elbow, and I think we're gonna do something for the upper back, just to show you how back is be treated, and I think then we can answer more questions.
Thank you, Alex and Peter, for these interesting cases. It's always captivating when you are talking about these cases. I think we have 2 questions from a practitioner. I don't know from which country, but let's read that. Hi, the topic is very good and lots of interesting cases. Here is my first question. Can all people with neck pain get shockwave treatment, or are there contraindications for some cases? And the second one is, do we need to come to an orthopedic doctor or medical rehabilitation first, or can we go straight to physiotherapy? Thank you.
Okay, I do the first part and the physiotherapist does the second part. Normally you can use it on every neck and on every cervical spine because most of the people are frightened of the arterias and so on. You don't have to be frightened of that because we don't use such a high pressure in this area where you can have the arterias, but normally you cannot not at all harm the arterias in the neck or in at the cervical spine part, or this is not possible. So we can use it normally with everyone. What you have to tell the patient is that they can have a tinnitus afterwards, means that they have for a few minutes or maybe a few hours this klingling sound in their ear, but this is going away in nearly every case, 99% after a few hours, and there's no harm anymore and doesn't stay there. So I don't see any real contraindications, not more than the contraindications, if there's someone who's taking pills for a better blood flow. It's of course possible that he gets a hematoma in the skin, but you know these contraindications and all the other things you can do.
Even if a person is suffering from a serious back pain in the middle, or well.
Yes, it doesn't matter. You can use it everywhere where the patient can stand the pain, and because we have a big range of pressure that we can use. I had patients, for example, at the thoracic spine, I used from 1.0 bar to about 3.5 bar, maybe 4 bar. It's depending on the patient, but if it's not too painful for them, you can always use it.
Okay, perfect.
And you will be surprised of the results, I'm sure.
Concerning the second question is, do we need to come to an orthopedic doctor or medical rehabilitation first? Basically, this belongs to how the rules are in your country. Yeah.
Exactly.
So me, for my part, I'm also working as natural part, and I'm allowed to do indications on my own. So patients can come to my practice and can be treated without seeing a doctor before.
Mhm.
If there's a rule or law in your country, then please make sure that you're doing it the right way. Yeah, if you need a receipt from the doctor to do your treatment,
Mhm.
then of course you need to see the doctor first. If not, then it's possible for you to treat.
Exactly.
I just go on with another question we got from Malaysia. Hello to Malaysia. Metal implants, or in all these fracture cases, we had this for lower for the legs, for fractures in the legs already. You don't need to be concerned about metal implants. There's nothing happening with the metal implant. Just keep in mind the shockwave is not going through the metal. Yeah, so you won't get any result after the metal plate, but for prosthetic implants in the knee or hip area, for example, they stay as tight in the bone as they have been implanted before. So always keep in mind, it's not a mechanical wave we are producing. Yeah, it's an acoustic wave. So basically, you're screaming at the metal. Yeah, and if you can scream that much that the metal is moving, then it was too loud. But no, we don't have any concerns about metal implants.
Yeah. And we have to say we even use it if the implants are not worked into the bone the right way. So if it's not as strong as you normally should have the way from bone to the implant or the prosthesis, we use shockwave to get it done for the rest of the bone healing. So if we use it for this, you cannot harm any metal implant.
Yeah.
And how long do you need to wait until for example, you have, well, surgery of an implant?
Mhm.
How long do you have to wait to get a shockwave treatment on the area where
We start at the day.
You don't have to wait.
Yeah, we start at the day when they are when they go from the hospital.
There's one thing you need
Okay.
to be aware. Yeah, you have a fresh open wound which has been closed after
Yes.
surgery. So use sterile gel, for example. Use
Some kinds of Foley.
disinfection fluid before treating it or during treating it. So the wound needs to be in a sterile condition. Yeah.
Okay.
But after some days, the wound is closed so much that you don't need to be aware, even if the stitches are still inside.
Yeah, that's right.
Okay. Perfect.
We also use it for scars, and so you get better scars and better wound healing if you do shockwave. That's it.
Like diabetic ulcers of the foot.
Yeah, it's the same. It's and that's an indication, an official indication is every kind of wound and diabetic ulcers and so on. So we have no problem with any kind of wound or stitches inside or something. We can use it on this.
There's another question
for a pacemaker. Oh, yeah, that's an interesting question. If you are not in the area of the pacemaker, you can use it. The problem is you have to have or you have to look where the pacemaker is. Sometimes they are not in a normal position, but they have to go more up to the shoulder or something. If you can reach the pacemaker, keep away from pacemaker. If you have to treat the other side or everything else on your body, it's no problem. Absolutely not. But in this area where it is placed and where the cable goes into the heart, keep away from there, but you can use it everywhere else.
Okay, perfect. Any other questions?
If there are no questions, we'll show you two things. We didn't talk about a normal tennis elbow, but everybody wants to know how we treat this. So we could do this. And I had the question about trigger fingers. Trigger fingers is special because you have to tell the people that you not always can get a real healing, because the problem is a mechanical problem. So if the trigger finger and the tissue that causes the trigger finger is too strong and too narrow, you can get the pain better, you can get the snipping better, but not away. So in most of the cases that are so severe, you really have to do surgery. That's clear. But we can show you what you have to do with this, or a Dupuytren contraction. You can also use it for this. You will get the pain better, you will get the feeling of the tissue better, but you cannot get all these movement problems away, because the scar tissue under it is too strong. Yeah, that's a problem. But we can show you how you do that. Okay?
Okay.
Okay.
Thanks.
Du trigger finger? Du was?
Du Triggerfinger,
Okay. So at the beginning, Alex will show you how we treat the elbow.
Thanks.
I take you with me. Is this okay?
We have to skip it, switch it. Doesn't put it. You just see the camera.
Yeah.
Yes.
You see Alex now.
Yes, we can see the camera.
Now you see my elbow.
Exactly. Yeah.
Okay, good.
Thanks.
Good. Alex is nice. He gives me a towel. Oh, my process.
We're gonna start with the maximum frequency of the device and start with pressure of 1.5 bar, just for your information.
Can you hear us?
Thank you. Yes. At least you deserve a towel, Peter.
Yes, yeah, it's an old one. We start on the painful area first. Yeah, I want to reach the threshold of the patient. No pain at all. So I going up with the pressure, reaching 2.5, which is painful now. Then doing little circles on the bone. Yeah. Yeah, I'm good.
So you're right on the bone. Okay.
Now I just switch the device off, because then you can hear what I'm talking, and I'm just simulating the treatment again. So what I did is, at the threshold of the patients, small circular movements over the bone. What is really important if I do this, I need to treat the muscle areas going to the elbow and leaving the elbow. So upper muscles going down to the elbow, yeah. Increase the threshold of the patient, go up till you reach the shoulder area, yeah. This is quite important to all the muscles reaching this elbow region. And also in this case, all the extension muscles going down to the head, yeah. And don't stay just in this area. Do the whole arm. Go down the whole arm.
And all the flexors, all the extensors, very, very important. And you always try to find the point where the most painful parts are, and then you can really stay on them to get the pain away.
What you can see, the way I'm doing the shockwave is some pressure in this area, and then like this is the only mechanical way I'm doing with my hand, increasing the pressure to get some mechanical massage effect on the muscle during shockwave. Yeah, this is a good treatment to release the tension also in the muscle area. Yeah.
He will put it on again now, just to show you 30 seconds how it works, and you can see the pressure on these marks here. You can see what he's doing in my tissue. Yeah. You see it? Can
Yeah,
you see how the marks are going? These marks are vanishing and coming back. Yeah, like this. This is very important for the feeling that you have in the tissue of the patient. And the patient gives back how painful it is, and then you can work perfectly.
Okay. We have a participant asking if it hurts on this area.
How it works.
Yes.
How it works or does it hurt?
No, it works though.
Which question, MC, do you mean?
No, the last one from AJ.
The last one,
Yeah.
right?
Yeah, it hurts. This is you saw it right his face. Yeah, right. This is quite important. It needs to be painful to reach maximum effect.
Yeah.
Always work on the threshold of the patient. I would say
Exactly.
6, 7 out of 10.
Yeah.
This is the pain you need to reach when you do shockwave.
Professor Smits always said, if the patient runs away and comes back with a lawyer, then it was too much.
As a joke.
As a joke. But you really have to work with the pain of the patient.
Yeah.
That's very important. And you can see that it gets better. Then you go up with the shock wave pressure, and then it's more pain. Then it gets better again, and so we can go up about 2 to 3 times with the pressure. That's important. And then you can show the patient, look, it gets better and better, and we can go up, and he can see and feel it's getting better and better.
Exactly. We have another question from a participant asking what size of applicator are you using for Gofferzable right now?
Basically, the situation, which applicator you're using, the big one, the small one, or there's also one in between. I already mentioned it's the important thing is to reach the threshold of the patient. Yeah. So if you reach the 6, 7 out of 10 with the big applicator in this area, then stay with the big applicator because it's just easy. Yeah. And it makes it more easy to treat the whole muscle area with a big applicator. After 2, 3 treatments, if you can't reach the threshold of the patient on the bone, then decrease the applicator. Yeah, and go on this spot, start slower, and again try to reach the threshold. Yeah, it basically there's no difference. The only thing is, if I have a diameter of 40 millimeters, then all the energy comes out of this diameter. If I decrease it, then I have the same energy coming out, but on a smaller spot. Yeah, which means more pain. Yeah, so work with the threshold of the patient in the area. That's fine. Then you have the right shockwave done. Then the other thing is, if you want to treat big regions like the whole leg or something, never use the small one. Yeah, because you need such a long time for treatment.
Yeah, if you don't have to do anything else.
Big areas, big applicator, small areas, small applicator, but all over this is always in the threshold of the patient.
And for example, for the whole back, doesn't matter if cervical spine or a thoracic spine or lumbar spine, you always use the big one. So you don't need the small one at all, especially at the cervical spine. I always ask if we need it for the small facet joints, you don't need it. Use the big applicator. It's much easier and it works.
We also mentioned the next question about the difference of radial and focused. Is it focused?
I think it's focused. It's
basically of the mechanisms, what's happening in the tissue. There's no difference between these two devices. The only thing is with the radial device, I've got cavitation bubbles which are causing the effect of shockwave. Also to answer a bit the first question I can see from Olivia.
From Olivia, and it's referring to the first webinar you did on theory.
Exactly, we will can answer this question in more detail after the webinar, but just to make the mechanisms more clear. When I have the cavitation bubbles with a radial device, I have got a total of around 4 centimeters cavitation bubbles. So I'm not just treating a certain spot, but I'm treating an area and more wider spreading, to reach an effect. Yeah, if I have, for example, a big bone marrow edema, which I just want to treat the edema, then I use the focus device, get the certain depth, go on this spot and just shoot puncture in a certain depth with a shockwave. You can see here Yeah, and I've got big plate and it's going together, and I have a certain spot depending on which deep I want to go. This is just the difference.
Yeah.
And the spot you aim on is very, very small when you use the focused one.
Yeah.
And the wider one if you use the radials.
Yeah.
Yeah.
I would say to show just now the finger and probably doing some back treatment, going a bit further.
Yeah, exactly. And Olivia, if you want to get more into it, I just invite you to watch the great first webinar we did.
Yes, there we explain it, I think, very in detail.
You can into details.
And you're of course invited for if you have further questions about mechanisms, because you can't tell questions. You get the email address from MC, and then we stay in contact after the webinar.
And we can also send you the first webinar that you can go through the slides your own if you want. There are all the explanations in it, and it's not so easy to tell this in a few sentences. The same with contraindications, because you have strict contraindications and you have contraindications that are that you have to look in another way on it, and that's not so easy to explain. So we would need about 30 to 40 minutes, I think, to tell this in a way that you can understand it. No.
But, yeah,
Okay.
We have webinar replays available, so you can watch them.
Okay, very good. So now we show you how we treat hands normally. Yeah, I think you can see it. MC? Yes.
Yes.
Okay.
Perfect.
I just want to show you how we do it normally, and not with a working machine now, because it's too loud. Important is that you always start where the problem is. So if you have a trigger finger, it's always the problem over here, and you start over the ground joints, and you always move it in the way that Alex told you before. It's a little bit in circles, and stay on the point where the most painful part is. And after that, you go through the whole finger and around the whole tendon that you want to work on, and go into the middle of the hand. And what I always do, or we always do, is we also go through the carpal tunnel. That's very important, because in cases where you have problems in your hand, on the palmar side, it is always the same, that you have normally also a problem with the metabolism in your carpal tunnel. So if you work like this, you can also have a lymphatic drainage effect. And we use this very, very often. We also use it on the carpal tunnel, of course. The carpal tunnel syndrome is a big problem. I don't know if it's the same in Japan, but in Germany, it's a big problem, the whole Europe. And we also use it to treat the carpal tunnel syndrome. Works very well. And if you have to stay on the point where the most the biggest problem is in a trigger finger, then you stay on it. Yeah. So you stay on it, you go up the whole finger, the whole tendon, and after that you go up with the pressure, as we said before. When the patient says, okay, now it's enough, then you do the same treatment again, always the whole finger. And here you can really use the big applicator. You don't have to use the small one, because you want a lymphatic drainage effect, and you hit on every joint that you need, and on the part where the trigger finger problem is inserted here. And then you go through all this, and after the patient says, okay, now it's getting better, then you use it a third time with higher pressure, and that's all you do. You can also use it for the sump and the joints of the sump, very, very important. And as you saw at the polyarthritis cases, you can use it for every joint and go over all the fingers to get a better feeling in the joints. For arthrosis, you need every joint normally, and a better feeling in the tissue, because you get this tension away. There's another question. Can we use directly to just finish on the area after operation with fracture? Yes, of course.
Definitely.
That's it. So for example, if he had a surgery here in the hand, maybe, for example, for trigger finger or dipytrin or something, there's the scar here. And then you can really start and go slightly at the beginning over the wound and over the stitches also. And then you can ask him, is it okay for you? At the beginning, maybe it's a little bit painful because it's sensible. But then after, I would say 30 seconds, you can hear the patient saying, okay, now it's getting much better, and then you can use it normally. And the same, and you don't have to be afraid of the wound. Go over this, and you will see as fast as the wound heals, you have never seen before, I'm sure. Oh.
How many sessions in total do you choose for trigger finger? Depends.
Yeah, for the trigger finger is normally a chronic problem. So it means if you start with 3 treatments in 3 weeks, sorry. Oh, sorry. If you start with 3 treatments in the first 3 weeks, it gets better, I'm quite sure. And then we normally go to a distance of 6 to 8 weeks, 1 treatment, if it's okay for the patient. Maybe at the beginning you can, after the 3 weeks, go to a distance of 3 or 4 weeks, do this 2 times, and if this is okay for him, then go to 6 weeks. But normally 6 to 8 weeks is what we reach with the patient. But you have to go on, you cannot stop completely because it comes back then.
And the real indication to do the surgery is if you, after your treatment or during your treatment, you can't get a better result and the patient is unsatisfied because he's not getting further, then this is the real indication for doing the surgery. Telling the patient that it's quite important after it to start immediately with the shockwave to get the whole area which has been
range of
done,
motion,
to get a better range of motion and get a long-lasting effect on this area, because otherwise the problem can be that because of scar and anything, it's coming back.
So if you do it 3 times and it's not getting better for the patient, send him to surgery and then tell him to come back as fast as possible after surgery and then continue. Yeah.
Okay, so you also need to restrict your activities. I mean, in terms of sports or
normally not at all. If you do a good treatment with shockwave and it gets better, you don't have to restrict anything. If you need surgery, you need surgery. But after that, when we can work with this, it gets much better than before, and everybody can do whatever he or she wants.
Okay, perfect. Get back to normal movement.
Yeah.
Any additional questions?
Then we're doing a session of back pain, just showing how we do thoracic, because we have some more minutes left, so it would be pity if we don't use it.
Exactly.
I think this is because everybody is asking normally, can we really use it on the cervical spine? Yes, you can, but they cannot imagine how to do.
And some, it's true that a lot of practitioners are reluctant to use it on the lumbar area because they have some they don't know how to use it. They are not sure if it's safe or so. It would be good to do a kind of reminder.
Okay. So. Wait a second.
MC, you are my second eye. My second eye is okay because I start and you can tell me.
It's perfect. We can see the lumbar area. We can see Peter well settled on the table. That's fine.
Just do one side to show you how it works. Okay, doke. Do it with some noise because he definitely needs to be treated, and then I will switch it off and explain something just because of pressure and what do I want to reach in this area.
Okay, perfect.
Because you can see it, it's a very nice thing on this side. Yeah, Peter really has problems with the lower back in this area. If you see me sliding over the area, it's going very smooth. Look at it when I switch the device on. When I be in this area, you will see it's very gluey, sticky, high tension in the tissue. And you can see it because the shockwave is not moving properly if I switch it on. So have a look at this. It's really good working here in this case. Very smooth. Going here. The thing, can you see it?
Yes.
It's not moving. Yeah, I'm moving the skin. It's sticky. Yeah.
Yeah.
So if the question is, how long do I treat this area? Yeah, as long as it's not sticky anymore, because then I will decrease the pain and the tissue is getting softer. So this is a good indication, right? When you feel it's getting released, you can tell the patient, now try it, it's better.
So the softer it is in this area, the better it is.
Yeah.
When
Even
you
if
know-
I have an area, a sticky area, and this, yeah, it's like I try to do like it is when I switch the device off. Soft, coming to here, not moving. Okay. So the same I do for the whole upper back. Yeah, stay on the area. If I have some problems going a bit more outside, treat this area. Stay on the painful spots going up to the neck. Even if you want, you can just go on the trapezius muscle. Yeah, because all these muscles in the area are relevant for the upper back. And also going up with it when you're doing the neck, yeah, or doing levator scapulae muscle, for example, go up till the end on the occipital area. Yeah. So this is the whole way to treat this area. I just try to get a point on the questions.
Yes, the question, can we use it to treat scoliosis patients, and how long the treatment takes for each section?
Basically, you can treat scoliosis patients, but you won't get a big change in deformation. If you have a bone deformation, we can't do anything. If it's caused by muscle tension, you can get a brilliant release in these areas, yeah, and can get some improvement of some degrees of these scoliosis patients. And you will get a big release in the pain and flexibility of the lasting properly working muscles in this area.
Yeah.
What is the purpose of shockwave for lumbar back?
Back pain, yeah.
Basically it's the pain release, but we also and of course, if I have a sacroiliitis or inflammation in the lower back in between the bones or something, or insertion of muscles, I can get an anti-inflammatory effect in this area. And I have got a nice mechanical effect I can reach by treating lumbar spine, which is basically insertion of psoas muscle area, going deeper to glutes, small glutes and hip extension muscles. I can increase the power of hip flexion and reduce the tension of psoas muscle, which makes more flexibility in the hip area. So just for purpose in this area. And most of the people suffering from low back pain can be treated exactly this way.
And we have a lot of cases of sacroiliac joint inflammation and facet joint inflammation, and you can really work anti-inflammatory in this areas without any injection. That's the most important thing. You do something for the hardened muscles, and you do a lot against the inflammation that you have there. And all the arthrosis patients with facet joint arthrosis are all suffering from a pain that comes from the inflammation. And the anti-inflammatory effect of shockwave is absolutely, yeah, not to describe it, so good, without any injection, without doing any harm to the patient. That's really great.
Exactly. Then I just switched to the last before I answer the first question left.
Yeah.
Can we use shockwave for fracture on lumbar back? Of course, it's a fracture. Yeah. It's the same. It's basically the same thing. Yeah. I'm treating the back. If I have a fracture, I'm treating also the fracture in this area. There's no difference between other fractures in this area.
And the bone consolidation will be activated. Yeah.
Exactly. Will be exactly the same. We are talking about fracture healing in general. Yeah. So all areas where I can treat with shockwave and I have a fracture, I can treat the fracture. Yeah. So we're doing right because it's also a little switch. The first question, and we can do the fracture question in the chest area too, because this is quite important. You don't have to be sorry for asking the question. It's an important question about air-filled tissue. Yeah. Here, we machen das mal simple, okay?
Yeah.
So basically, we need a contraindication is to do shockwave or air-filled tissue. So I don't do the stomach, the belly. Basically, there's also nothing I want to treat. Yeah,
The
I can't.
kidneys, yeah,
Pardon?
the kidneys as well, the lungs.
No, kidneys is no
In
problem.
this area in the back, I don't have a problem with air-filled tissue because I have too much tissue over the lungs that I am not able to really reach the lungs. And if I have a really skinny person, for example, and probably reaching a bit of sensible area there, she is just a bit coughing, and I know, okay, I go to another place because I don't have so much energy from the back to reach any difficult area. So you're definitely allowed to do it on this side. Don't have any problems. Just to explain, if I have a scapular fracture, I can go on the scapula, of course, yeah, because then I don't have any problems to get to the lungs. So if I have got rib fractures in the chest, yeah, I'm not very concerned. It's the same thing. So if the patient is coughing, I go to another place. If I want to really be exact on the treatment of these bone fractures, I'd use my two fingers.
Yeah.
Mark the rib which has a fracture. I know the fracture is in this area. Use this applicator, and then I can treat very nice on this bone to make a healing process in this fractured area. So this is just to keep it simple. If you want to make sure, be sure 1,000%, but you don't need to be worried from the back in this area. You don't reach any air-filled tissue. Yeah.
Okay.
In all other cases, to treat from the front, for example, if you want to treat the diaphragm muscle, it's just a way about how you want to reach it. If you can you turn around for a second?
Yes.
Yeah. I'm gonna show you because it's very helpful, especially in times of COVID, lung COVID, and breathing problems, or after surgeries. You really can use it, and it's belonging to the chest, and it's important. So if I have the diaphragm, if I have the diaphragm here, for example, yeah, I'm not shooting on the diaphragm like this because there's nothing I want to treat, not straight in the stomach, but there is no contraindication about using the shockwave and shooting this way. Yeah.
Yeah.
Then I don't have any problems reaching difficult areas which I'm not allowed to. Yeah, the same thing I've got with the iliacus muscle in this area. I'm not shooting on this like this directly in. Yeah, I just go from the side to the insertion of the muscle. Yeah, and to make it complete in the front side, if I have inflammation of the pubic bone, yeah. There are two possibilities. Was heißt Bladder? I sent the patient. I tell the patient not going to toilet to leave the bladder full. Then it's not air-filled tissue. If I can't manage this, then I don't have a problem. I do it the same as with the ribs. Mark the top of the symphysis, below the symphysis. Take the applicator and go directly straight from the top on this area.
Okay.
So. And then you cover most of all indications which really needed to be treated, yeah, without touching air-filled tissue. So nobody really needs to be worried. Yeah.
What about do you get a successful impact with shockwave on how do you say that, disc herniation?
Yeah.
Yeah.
Herniation?
Or yeah.
Yeah. Okay. Hernia of a disc in your back. Yes, if there is a swelling in the disc, you can improve the swelling and get a lot of the pain and maybe the neurologic symptoms away. You cannot heal it completely, but as everywhere, you get an anti-inflammatory effect, you get an anti-edematous effect, means the swelling goes away. And if this happens, the problems go away too.
Yeah, so you can, well, I would not say that you avoid surgery, but at least you can bring, well, some
Yeah, you can,
lot of
in
relief.
most of
I
the
mean.
cases, as you have seen with the guy that I treated
Mhm.
on the
Yeah.
cervical ending, it gets better and he doesn't need any surgery.
Ah, okay.
And for the people are afraid of lung problems after the treatment, there hasn't been one single case in the whole world that radial shockwave could do any harm on the lung. That's really important. Not one case in the whole world over the years.
Brilliant.
It's the precaution, yeah.
And thank you very much for the
Well,
audience for so many interesting questions
Yes, it
and
was great.
taking part of this webinar. It's really nice if we have this interaction, even if we are not close together. So
Yeah.
thank you very much. We come to an end. I
Yeah.
hope we
have to be
mentioned
punctual.
everything. Yeah. If there are further questions, don't hesitate to ask MC for more information, which we will supply very
Easy and very fast
Yeah.
if you need it.
Okay. Thank
problem.
you again, Alex and Peter. It was so interesting, and I'm sure everybody enjoyed it. Thank you all. We will see each other next year online, because it's the end. It's almost the end of the year, so we will see each other next year. So have fun with your shockwave devices and with your patients. And feel free to send us some questions, and see you next time online. Thank you again, and
All the best.
take care. Bye-bye.
Bye bye. Thank you.
Bye bye.
Bye-bye.